Welcome to our webinar today, Accelerating Door-to-Puncture and Door-in, Door-out Times. It's a review of the Target Phase 3 paper. My name is Jeannie Luciano, and I am the Senior Manager for Stroke with the American Heart Association. Next slide, please. Just want to bring your attention to our Get With the Guidelines suite of programs. If you have any questions, you can, or if you are interested in participating, you can scan the QR code or go on to the site at the heart.org site and contact us. Next slide, please. Just a disclaimer slide. The recommendations and opinions presented by our guest speaker may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by AHA, ASA, or AHA, ASA does not endorse any product or device. Next slide, please. Some housekeeping before we get started. So a recording is in progress and with all attendees in listen-only mode. The slide deck will be available in the chat box. You can see the PDF of the slide deck now during the presentation, and will be sent out with the recording after the webinar. A link to the recording will be emailed following today's presentation. If by any chance you experience any technical difficulties, try refreshing your browser, logging out and back in. If these steps do not correct your problem, please contact the Zoom customer service team. We will be taking questions and answers in the Q&A section, so this can be entered at any point in time in the Q&A box at the bottom of your screen, not the chat box, but the Q&A box. Closed captions are available by clicking the icon at the bottom of your screen. Next slide, please. We are extremely fortunate in kicking off 2026 with such a wonderful and informative presentation by our esteemed and very energetic speaker. So I would like to introduce Dr. Kaiz Asif. Kaiz is a neurovascular surgeon and vascular neurologist based in Chicago for the last 10 years. He has been the medical director of a large health system, and in addition to his clinical and administrative work, he serves as faculty at the University of Illinois, Chicago, and holds leadership roles within national neurointerventional societies. Dr. Asif is passionate about access to stroke and neurointerventional care and has been an invited speaker at several major national and international conferences. So we are very fortunate to have Kaiz with us, and Dr. Asif, I'm handing it off to you.
All right, thank you very much. Jeannie, let me know if everybody can hear me okay?
Sounds great, we're good.
Great, excellent. Thank you again, Jeannie, for the introduction. Thank you, the American Heart Association, for this invitation. And I just want to, that introduction was great, and I appreciate that. But I want to make sure that everybody gets a context of who I am and what this talk is about, really. And there are two hats that I wear. One is this clinical hat of neuroendovascular procedures and clinical work, everything that comes with it, including administrative stuff. And then there is the second hat, which is basically neurointerventional public health. And that term actually doesn't even exist, but that's what I do in that second role. And all the association with American Heart Association or FSVIN or World Stroke, and the work that is done in that direction is to increase access to neurointerventional care, particularly to mechanical thrombectomy for stroke, not just nationally, but globally. So that's the second hat, which led to this project that I'm going to talk about. Okay. These are my disclosures, nothing really relevant to this talk. Now, most of you, if not all of you, are familiar with Target Stroke. You know that Target Stroke is AHA, ASA's quality initiative, and phase 1 was launched in 2009. And this was built on the success of the Door to Balloon Alliance in cardiology and the success of the Get with the Guidelines registry and the Brain Attack Coalition to develop a quality initiative for stroke. This was actually the first true national quality initiative. And the initial goal was look at this, 50% of TPA or IV thrombolysis within 60 minutes. If we look at this goal right now, it looks too soft. We've become so ambitious right now. But at the time, this was a major thing. This was not existent. There was no real benchmark. And so this goal came about after an expert group of physicians who developed these 10 key evidence-based strategies. So this paper was published in 2010, 2011 that looked at literature and reviewed and developed these 10 strategies for target stroke phase 1. Okay. So this was launched in 2009 and 10 strategies were developed. And these strategies now are very familiar to us. Now, for those of you who are stroke coordinators, navigators, stroke APNs, you are very familiar with these strategies. But at the time, they were not implemented. I remember this. I was still in fellowship when these were released. And, the university hospital that we were at, this was not a done thing. So these strategies were really important to implement at the time. And these included, as you can see, pre-hospital notification, the triage protocol and stroke team notification, paging, single paging system, and stroke toolkit with order sets and so on. This included the rapid acquisition of brain imaging, meaning, quick moving from the ER to the scanner, rapid lab, and then TPA-related, thrombolysis-related things, premixing, and then potentially giving it in the imaging area, a team-based approach and feedback. So these were the 10 strategies, okay? The next step was this paper looking at what was the impact. So released in 2009, the strategies were implemented for the next 3 years, and then looked at on what was the impact. And it increased thrombolysis use, which is not surprising, but really important, that in eligible patients arriving by 2 hours and treated within 3 hours, increased from 64% to 85%. That's a huge change. And within 4.5 hours, increased even more in terms of the degree of increase, 22% to 63%. And all right. And then this is showing not just an increase in the number of TPA administrations, but the number of patients or the proportion of patients that were administered within 60 minutes. And you can see from 2009-10 that upslope, which is quite steep, and showing how much of an impact the 10 strategies and the implementation had. This was then followed by Target Phase 2, which was in 2014. And this became more ambitious, obviously. Now, you wanted the door-to-needle time of less than 60 minutes in 75%, not just more than 50%, but 75%. And a new metric of 45 minutes was introduced for more than 50% of the patients. So more ambitious, in terms of the times and in terms of the strategies. Besides the 10 strategies that were with Target Stroke Phase 1, 2 additional strategies were added, which is a timer and a clock. And anybody who's worked with me, whether in the IR suite or in the clinical area with stroke patients, knows my obsession with timers and making sure that clock. So this is a huge, a very important change to have timers and to ensure that there is certain time set that at this point somebody calls out. That's what we do in our processes, that somebody calls out that we are at 10 minutes or we are at whatever time, so that everybody in the team knows how we are doing. And then the second thing was transfer directly to the scanner, not stopping in the ER, not connecting monitors, not getting all the other exams done, and then moving to the scanner, but directly to the scanner. Even this is taken for granted right now. I mean, I'm sure that none of you, it wouldn't come as a surprise that this is a recommended practice, because we have gotten used to doing it so much. This is 2014, remember. So then the next step is to measure, right? So you develop quality metrics, which are evidence-based, implement them, and measure them using Get with the Guidelines registry. So this is the paper that looked at what was the impact of phase 2. And, the door to needle less than 60 minutes continues to go up. So you can see that change from phase 1 to phase 2. There is an increase in the number of patients that are getting within 60 minutes. And not just that, look at the change after phase 2 in 45 minutes. There is a slope, which from phase 1 to phase 2, but it becomes steeper after phase 2. So once the target is given, once a target of 45 minutes is given and is measured with that metric in mind, it automatically changes, to some extent behavior, to some extent providing more resources, being able to justify more resources that are needed to meet that target metric. Now comes phase 3, and this is in 2017. And remember, 2015, thrombectomy trials have been published. And if you noticed, until now, in phase 1 and 2, there are really no thrombectomy metrics, because thrombectomy was not even a thing, or established thing. So in 2017, when the target phase 3 is released, now we have, in addition to the TPA, the thrombolysis metric of less than 60 minutes in 85%. So started with 50%, became 75%, and now is 85% in less than 60 minutes. Now we have additional metrics for door-to-device times as well. So arrival to first pass thrombectomy device is achieving door-to-device time in 50% or more within 90 minutes. So that's for directly arriving patients, and for transferred patients within 60 minutes. That's an added metric which did not exist earlier, and now Target Phase 3 introduced that. What are the strategies? So we looked at, and then the door-to-needle times, of course, the 45 minutes and a new metric of 30 minutes is introduced. So we had 60 minutes in phase 1, we have 45 minutes gets introduced in phase 2, 30 minutes gets introduced in phase 3, and in just 8 years, 2009 to 2017, the expectation goes from more than 50% patients getting it within 60 minutes to more than 50% patients getting it within 30 minutes. That's terrific. And what are the strategies? So you looked at 10 for phase 1, 2 additional strategies added in phase 2. And then in phase 3, there are strategies that build on for thrombectomy. That's what we are here to talk about. So number 1 is rapid administration of TPA, and that means follow phase 2 strategies. Number 1 is actually all phase 2 strategies combined into one point. And then we have imaging-based strategies, so which is the rapid acquisition of CT and MR angiography and additional imaging, which did not exist earlier. But now with thrombectomy and large vessel occlusion detection, that is added. The other is neurointerventional team activation, pre-notification, team activation, and rapid availability. Then what to do for the IR suite, so directly to IR or CT to IR, and endovascular ready neuroangiography suite. And then there is this team-based approach. The other thing that phase 3 did were door in, door out best practice strategies, and in particular, the use of telemedicine. So phase 3 came with the strategies building on phase 2, adding particular specific things for neurointervention and rapid door to puncture in mind, and then door in, door out strategies as well. All right. Now, before I go to the paper that I've been invited to talk about and that I had the fortune of being fortunate to be a part of, I want to talk about a couple of other things. One is this is a Get with the Guidelines analysis by Amanda Hagolina-Cole and our group, looking at rural areas. So if we look at any patient that is transferred from a hospital to another hospital with the intent of receiving thrombectomy, does it matter if it's a rural zip code and how much? And I don't want to go, cannot go into a lot of details on this. Please look it up. But a rural-based transfer had 15% reduced chances of receiving mechanical thrombectomy. And, the reasons could be varying from delayed recognition, delayed presentation, lack of availability of vascular imaging in rural areas. So transfers that then did not turn out to be large vessel occlusions. But those patients that had an intent of getting mechanical thrombectomy did not end up getting, and that difference was 15%. So keep that in mind as we go further. And then the other thing is this paper that we worked with the SPEED committee at FSVIN, where we looked at the large vessel occlusion stroke knowledge in stroke severity assessment amongst emergency medical personnel. So all 50 states, a wide survey through EMS World, 1,100 respondents, asking them about their knowledge. So there were knowledge-based questions, LVO knowledge-based questions, and then measuring, their experience, looking at their number of strokes they transfer, and so on and so forth. So all the factors, their experience, whether they are permanent or not, how many strokes do they transfer, what kind of stroke education do they get, have they received an LVO-specific education, so on and so forth. So these factors were looked at, and knowledge was measured. And what we found was that only 12% of those EMTs could answer the question related to stroke centers, meaning levels of primary comprehensive thrombectomy capable stroke centers correctly, or identify which center does what. And only 25% could answer both knowledge questions. There were 2 knowledge questions, both knowledge questions correctly. And what that tells us is that there is a considerable lack, there's a gap in terms of LVO knowledge in amongst EMTs. And the one single factor that correlated with that knowledge. So when we looked at knowledge, we correlated with factors, experience, number of strokes they attend to, urban, suburban, rural location, so on and so forth. The one factor that correlated with on LVO specific training or not. For those who had received, their knowledge was good. For those who had not, the knowledge was lacking. Second thing was that overwhelmingly, the 48% of the respondents said standardized LVO-specific education would be beneficial to them. So keep this in mind. Keep the fact that rural thrombectomies, rural patients don't get as many thrombectomies on transfer, and that EMT knowledge is lacking. So let's get to the phase 3 paper that we're talking about. And I had the opportunity to co-lead with Brian McGrory and a fantastic big team. As you can see, a lot of authors on that paper. But this is our way of measuring. So I showed target phase 1, implementation, execution, measurement, implementation, execution, measurement. Same thing with target phase 3. We implemented it 2017 and then measuring it. So how did it start? And this is, I will detour a little bit on how well-structured American Heart Association systems are and committees are, and how things can be implemented. I joined about 6, 7 years ago, and when I joined, it was the Emergency Neurovascular Care Committee, which it's there that I had proposed the idea of understanding pre-hospital and in-hospital factors affecting mechanical thrombectomy. So we developed a survey where we would ask about pre-hospital severity scale use nationally, emergency response to pre-notification, what kind of bypass and rerouting is done, what kind of pre-hospital technology is used, MSU or not, and then feedback is given to the EMS or not. These are pre-hospital factors. The in-hospital factors, we wanted to know more details for detailed ER workflow, just breaking down the details of ER workflow. Concurrent vascular imaging or not, automated software use or not, meaning the software platforms for automated detection and perfusion imaging. And then neuro availability, telestroke use or not, and if telestroke is used, how is it used? Is it outside vendor, inside telestroke, et cetera, et cetera. So this survey was then proposed to Emergency Neurovascular Care Committee, and I'm just showing how connected and well organized HA committees are. That this was then taken. So we wanted to not just do a survey, but also measure, meaning how does this impact, or what we found on the survey impacts care. So this was then taken to the Stroke Systems of Care Committee that oversees Get to the Guidelines. And we then collaborated on developing a survey to look at these points as well as target stroke phase 3 strategies and see if we can look at Get with the Guidelines hospitals, get the survey and understand these factors and correlate the outcomes in terms of door-to-needle and door-to-puncture times with the target phase 3 strategies and the responses to these questions. So it was a web-based survey and many of you, I'm sure, participated in it. Many of you in the audience that are stroke coordinators or stroke medical directors participated in the survey. This was sent to 2,500 plus hospitals, 2,528 hospitals. And we had the data collected because remember, 17 is when target phase 3 is released. So we wanted to collect data after the implementation of phase 3. It's from 17 to 22 and included all patients that got EVT and IVT. So anybody who got EVT and IVT, but excluded in-hospital stroke or anybody who got it beyond 24 hours or patients who received as a part of some kind of a research trial. And there were 3 overlapping cohorts, as you can imagine, the ones who directly presented to the EVT hospital, the one that were transferred in, and the one that were transferred out from a primary hospital or a non-EVT capable hospital. And then what we looked at is how these strategies impacted door-to-puncture times at the receiving hospitals, whether it's directly presenting or transferred in, and how it impacted door-in, door-out times at the transferring hospitals, right? And they were then statistically analyzed using generalized linear models. So we had about a 60% response rate, which is fantastic in terms of, and that again shows the machinery at work, right? It is not easy to have more than 2,500 hospitals sent a survey. And to get responses in more than 1,400 hospitals. That is fantastic. This then translated into more than 37,000 patients that were directly arriving, about 28,000 patients that were transferred in, and about 12,000 that were transferred out in terms of the number of patients. So what are the results? And the results in terms of door-to-puncture affecting strategies, right? And I'll talk later about door-in, door-out affecting strategies. But which phase 3 strategies were positively associated with door-to-puncture times? And the shorter door-to-puncture was seen when neurointerventional workflow. This is not surprising, right? But now this is some degree of measurement and data to it. Thrombectomy works for stroke is not surprising, but we needed data to be able to get into guidelines and to change indications and so on and so forth. So similarly, we need data. We know this intuitively works, but how have we measured it? And that's what this attempt was. So alerting the neurointerventional team based on EMS pre-notification, that's positively associated with no surprise. Again, this simultaneous performance of CT and CT angiography in patients presenting less than 24 hours, regardless of their NIH stroke scale. So no NIH stroke scale cutoff used and that was one of the questions in the survey, that if simultaneous imaging is done, that in itself was associated with reduced door-to-puncture times. And then telestroke, increased use of camera, shorter DTP, the longer door-to-puncture, and this is again not surprising, that adding a CT or CT perfusion that would otherwise not be performed to a test later. So, the old style of going for a CT, then coming back to the ER, then deciding for the CT angiogram, then going back to the scanner, obviously that will delay things. And then this was a little surprising, that the bypass and rerouting was associated with longer door-to-puncture times. Door-in, door-out times, we had EMS specific factors like patient-specific data feedback to EMS providers. So remember, door-in, door-out is to non-thrombectomy capable centers that are transferring patients out. If the EMS around that received data feedback on how they are doing, the door-in, door-out times are better. If, again, simultaneous performance of vascular imaging. So not only is door-to-puncture times better at thrombectomy-capable hospitals, but door-in, door-out times, because there is early detection of large vessel occlusion. So if you simultaneously perform vascular imaging and use of automated neuroimaging software, which, as many of you know, the data is shared easier, faster, and with images with the receiving hospital as well. It makes all of that possible. So that reduces door-in, door-out. And if IV thrombolysis is done in the imaging suite, meaning the scanner at the primary hospital, which all makes sense. If you performed large vessel occlusion imaging concurrently on all patients within 24 hours, which means you detected LVO faster, if it was with a platform that could share images really quickly, and if IV is given in the scanner, it would reduce door-in, door-out times. And telestroke. So telestroke providers based at the hub facility within the same health system, which means that because the communication is faster, if telestroke is being provided by a connected network. So limitations, well, it was a survey, so that is always a limitation, self-reported survey data. Second, The findings are associative, which means that it's not patient level causality that can be established. You know, we can only associate findings. They're not the causal relationship is difficult to establish with this, and this was only with in 40%. But I mentioned this as a limitation, although imagine 40% of you national get with guidelines hospitals that were covered in a study. That's a lot of patients. But of course, 60% were not. I will stop there, but before I do, I want to share these two papers. One is the rural statement that I could co-chair with Corey Zackerson, which is the first rural American Heart Association statement for rural stroke. So that please check it out. And there are some good strategies mentioned, particularly with rurality in mind. And then this is the paper that we just talked about. Thank you very much.
Thank you, Dr. Asif. That was a really comprehensive look at in really looking at the impact of the entire systems of care and the chain of survival for our acute stroke patients. We have multiple questions here, so I'm going to try to tap through these a little bit. The first question I have here is one of the shorter door-to-puncture strategies you presented was simultaneous performance of non-contrast CT and CTA for patients presenting within 24 hours of last known well. How do you prevent extended door-to-needle times with thrombolytic therapy?
Yeah, that's a great question. And that is always a challenge, right? This is not an easy thing. My answer to that would be to utilize or try thrombolysis in the scanner, which in itself has been a strategy proposed since phase two, and has shown reduced door in, door out times already in the talk that I just gave. So if one has the ability to, get because this is about workflow. If a hospital develops a certain workflow for every single stroke code to get CT angiogram, then one sees that the ability to get them quickly is also, it gets quicker and quicker. The more one does it, instead the techs get trained better. They know exactly what they are doing on a particular patient, and there is no decision to be made whether this person needs CTA or not. If you're doing concurrently, then everybody knows there is more experience with it. And if you have a system where you can give and assess based on the initial CT while the CTA is happening, the decision making based on CT is happening, the thrombolytic medication is being prepped, and as soon as the CTA is over, which takes whatever additional time, that time is used for decision making for thrombolysis, evaluation for CT, consent, whatever other things that are needed for post CT TPA administration time. That can be used for the CTA to be performed, and TPA can be administered right in the scanner. That would be the most ideal way.
And I forgot to state that if anybody has additional questions, you can still be entering your questions into the question and answer panel. So I guess building on, I think we have a radiology employee here who says, did you find any impact on general CT throughput by administering thrombolytics on the CT table? So I guess you're taking time up for a intervention in the CT room. So any thoughts on that?
Yeah, very important practical questions, right? And the again, TNK has made things a little bit simpler. Preparation is easier. It's a bolus administration, and so on and so forth. So I think that again, we did evaluate and we did write about our TNK experience, but that was more in terms of the clinical outcomes. But I think there is some data on time metrics being affected as well with TNK. If that is used, I think that one can reduce that time on the CT table and solve that problem.
Okay, thank you. There's a question about what LVO assessment tool for EMS has been shown to be most accurate in both sensitivity and specificity.
Yeah, there was a time when I was when the stroke trials were published, every few months we would have a new LVO stroke scale, and we counted at some point there were like 12 or more LVO stroke scales. There have been 4 that have been validated in the field with EMS personnel. And there is really no head-to-head comparison. So, the accuracy cannot be compared to one against the other type situation, but the overall general sensitivity and specificity or accuracy is very comparable for the 4. And the 4 I say because of the validation that they've had, which is Lamb's FAST-TD. I believe it's VAN as well. But what matters more in from literature and from our personal experience is not which scale, but how well is that scale taught to your local EMTs? How much feedback are they receiving on that scale? How much re-education are they receiving? Those things matter more than which scale it is.
Okay, great. There's a question here for those facilities doing lytics in the scanner. That basically builds on. It's another question about tying up the scanner for treatment. So I'm going to move on to another question. There's a question here. What type of timer system have you seen utilized that works best for tracking where you are within your time goals to keep the entire team involved in the importance of the time sensitivity in the moment? So I said you love timers. What's your favorite timer system?
Yeah, I wish I had the timer with me here. But it's a digital timer which everybody can see from a distance, which has a certain inbuilt alarm system. That's what we use. And even in the IR suite, we have this timer which is switched on as soon as the patient enters the room. As the patient is being brought in, switch on the timer so everybody can see how long it has been to get the patient off the table, on the getting anesthesia on, getting lines, etc., etc., etc. by the time one does the puncture. And even after puncture, we have times that are for getting up to the target vessel and so on. So that's for the IR suite. For the timers in the stroke workflow, if somebody can switch on a timer, there's a launch pad. We keep a timer there, which is a kind of a digital small set. But you can use whatever works for the whole team. Anything that is visible, that the entire team can see and has some kind of an inbuilt system at half an hour, it goes off, reminding the team how much time it has happened.
Okay. So there's a question here. Can you explain a little more about alerting neurointervention based off the EMS pre-alert? Are you activating the neurointervention team based off that, or just alerting the provider? What about falsely elevated scales without an LVO? And does a team respond? If it's not,
Yeah.
do they go home? And then it says at our facility during off hours, the team is called in and not sure how well this would go over. I guess it's like, at what point in time do you, alert them and say, head on in?
Yeah. No, the alerting doesn't mean come in. So the team is not coming in based on a pre-hospital notification. And whoever has asked this question is right. I mean, the accuracy, the skills, at least that's not what we practice, and that's not what we meant by the question. What we meant by the question was informing the neurointerventional team about a patient with a certain, with a certain race score or with a certain NIH stroke scale based on ER assessment if the pre-notification was not there. Because not if the pre-notification did not include a high race score, for example. A race is what we have used in our region, but whatever LVO score that the EMS is using, if that meets the cutoff for your LVO, and you can let the interventional team know about it, that there is an expected patient, then there is a certain degree of preparation. And that preparation during daytime can include things like you can change your workflow a little bit, hold off on a scheduled procedure that you're doing, make a second room available, have a second provider if there are concurrent patients going on, things like that. Those are not major things, but those are small changes that can be made based on that alert and then can be called off after the patient comes in, or if the patient didn't have a pre-hospital notification, got the first exam in the ER, you have set a certain NIH stroke scale for your whether it's 6 or 8 or whatever one uses. In our case, it is 6. So anybody with an enhanced stroke scale of 6, the neurointervention team knows that there is a patient like that, so that you can adjust your workflow if it's a daytime. If it's a nighttime, you're not coming in, but everybody knows that there is a possibility of that happening. And as soon as the scan is done, the neurointerventionist is expecting the scan to be done. The neurointensivist is, everybody who's involved in that pathway knows that there is, so that reduces time. But no, the answer is that if interventional team is coming in, they're not.
Okay, there's sort of builds on that. So is the process the same when you're getting a transferred patient from an outside hospital as opposed to a patient who presents to your emergency room? You clearly have more information about the patient who has already been somewhat worked up in the transferring facility.
Jeannie, say that again. I didn't get that.
Yeah, so it kind of builds on when do you activate the neuro IR team if it's a patient transferring from an outside hospital? Is it the same kind of process as when they present to your emergency room?
Yeah. So I mean, again, that's the thing about systems of care. They are very difficult to standardize because they are dependent on many multiple stakeholders. You can standardize a thrombectomy procedure, but it's hard to standardize workflows for systems of care. And I say this because it's variable if you are a hospital that receives patients from hospitals that have or do not have certain capabilities for imaging, have or do not have certain workflow for imaging. They perform concurrent vascular imaging or not? When you are getting called, is it a call that is made without a angiogram, CTA or MRA, or with? That matters because for a call that is made where you have a confirmed LVO and so on and so forth, you know exactly what you're dealing with. In that case, you can call the team in and save that transfer time. So whatever time it takes for the patient to transfer, the team is already ready waiting for the patient. So that reduces the door to puncture for the transfer patient. That's why I say that for transferring hospitals, it is important to perform concurrent imaging, and which reduces their door in, door out time, and which increases the propensity of the patient getting thrombectomy at the receiving hospital. So, in our system, everybody who's coming in from outside has had the vascular imaging. So we are activating the team.
Great. Here's a question that talks about the interventional suite as well. So could you share some key pre-op best practices to integrate with our anesthesia colleagues in mechanical thrombectomy to speed up times when general anesthesia is the default? I know anesthesia overall is a area of discussion, but do you have any best practices with your anesthesia colleague?
Yeah. So, which is again very specific, which is a discussion, which is making sure that every anesthesia provider, these are things that are usually not discussed, um, because they are all communication-based things. But having a clear line of communication with whoever is going to provide anesthesia in a stroke case, whatever number of providers they are, making sure that there is some kind of a communication with the anesthesia team, whether it's in their meeting, so their monthly meeting or whatever, that somebody can go and talk about exactly what the expectations are, why that is an important thing, and so on and so forth. And devise some kind of a plan, that an agreement, that is it okay while patient is being intubated, somebody is getting access. Is it okay? For example, I personally do not need an arterial line. Um, so is it okay from an anesthesia side that I would prefer not to get an arterial line? If we need it, we'll do it. We'll throw it from the sheet. Those kinds of things, those kinds of agreements, that it is okay that we can puncture at the time that intubation is being done. That we really, really would like the induction not to drop the blood pressure, not to have hypotension during that time. We would really want to make sure that the patient is outline is not done. So those kinds of agreements, I think they all shove off some time. The other thing is a standard process. So if there is sometimes MAC, sometimes no anesthesia, sometimes general, um, which is okay, which is very provider dependent and how everybody likes, and also workflow dependent on how your teams are set, how soon the interventionist is arriving, so on and so forth. Um, but if there is a standard system, one system, then that becomes fast. It's like CT angiogram. You remove that decision making, everybody who gets on the table, CT angiogram has been done. Everybody who gets on the table is getting general anesthesia. In our experience, again, I won't have data to back that up, but I'm whatever I'm saying is what my experience of managing this and seeing this over the past 10 years has been.
Thank you so much for that answer. There's a question here around, there's several questions that talk about direct to angio for your transferred patients. Do you have experience with that, and any words of wisdom on that if you do have experience with that?
Yeah, it's an exciting new thing for sure, and there are trials that are going on. Um, we would be looking forward to participate, hopefully, in one of the trials. But this question will be definitively answered. Again, many workflow related factors. What criteria, what cutoff, uh, what kind of workforce capability does one have? But I think that um, based on what we have from Catalonia trials on direct to angio, there's no US trial. The US trial is going on right now. Is that it makes sense if there is a certain degree of clinical cutoff that is used, at least during daytime when the team members are here, um, and the neurointerventional suite capability is there. I think it makes sense to get the scan directly on the angio table.
Great. Two more questions here. So this is actually obviously a exacerbated stroke coordinator here. Door in, door out is challenging in our center due to availability of transportation and availability of beds. I don't feel like I can impact these factors. Do you have any recommendations?
So door in, door out is challenging because of availability of transport, you're saying?
Availability of having intra-hospital transport
Yeah.
and availability of beds at the hospital that is accepting I guess, like a comprehensive stroke center or a thrombectomy capable center.
Yeah, I sympathize with that problem, and trust me, we've dealt with that. I mean, I've been the director for a health system that had three comprehensive stroke centers and 14 spoke centers. So, and this is all across Chicagoland, Southern Illinois, and so on. So we know about I do realize the challenges that are there, and there is no other way but to basically keep working on it with the EMS, keep finding some kind of a sweet spot on when would it be feasible for the EMS that is bringing the patient to the transferring hospital, the primary stroke center, to not leave right away. It could be a certain race cut off, large vessel occlusion score cut off, and so on. But if that can be possible, that it's the same EMS that brings the patient and transfers, and I know that that is not always possible, that is ideal. And then as soon as possible, some kind of a pre-notification. These are standard practices of establishing a contract with the receiving hospital and pre-notifying them as soon as possible and image sharing as soon as possible to avoid and to avoid that bed situation problem, or at least giving them some more time to arrange for a bed. That's all I can say right now.
Yep, and we're hoping to help you with this in the future as we try to improve this time frame for our patients. One more question, and I guess this is a good question to end on. Is there any thought about going too fast that safety and decision to treat gets compromised?
Yeah, that's a great question, and we always worry about it. We always remain mindful of it. Um, I think that the for thrombectomy, uh, I don't think there is that worry as much, in the sense that if you have this, the criteria is fairly well established. Even large core trials are positive. So, if core was an issue in terms of safety, we now have data. We now will have guidelines which will have class one recommendation for aspect score 3 to 5, and class 2B, class 2A type recommendation. Again, the new guidelines that potentially will come out will have recommendations for even less than 3 aspect score up to a certain age, and so on. So people who are involved in that decision making, and that's why, and this is, I'm talking not for IV thrombolysis, because this is our talk is about thrombectomy and all our things pertaining to thrombectomy. Uh, Going too fast is not leading to the improper decision. It is important to make sure that the team that is making the decision is involved as soon as possible and has all the data that is needed to make that decision, the scans that are needed to make that decision. Which is why concurrent imaging, repeatedly I've mentioned this, and early activation is important. And then people who are making this decision should have understanding, of course, of distal vessel occlusion, the associated NI stroke scale, the patient's modified ranking score, the NIH stroke scale, and the degree of disability that is there, so on and so forth. So yes, you should be mindful, but I don't think it should come in the way. You can achieve both. That's what quality initiatives are for, that you implement systems that ensure that while you are speeding things up, you're also doing it safely.
That's a great way to end today's conversation. It always amazes me when you see how fast things go once you get that patient on that table. So that's always amazing to me. So I would just like to thank you, number one, Dr. Asif, for your tremendous presentation. I wanted to thank all of our listeners and our participants for your contribution, really, to the successes of the Target Stroke initiatives. You are just key individuals in making these successes and helping us to, for lack of a better term, push the needle even further, right? So I think we can look forward to that happening in the coming months to year. We're going to start pushing the needle further. And I want to really encourage, especially my nursing colleagues, start to ask these difficult questions and look at things from a QI perspective. So on behalf of the American Heart Association and our wonderful presenter, I want to thank you for joining us and wish you all a happy and healthy 2026, and enjoy the rest of your day. Thank you. And thank you, Dr. Asif.
Thank you. Thank you, Jeannie. Thanks, everyone, for attending.